You had a very interesting topic to present. Is it the end of the statin, the king statin? With the advent of newer agents like PCSK9, do you feel that role of statin in the current management of cardiovascular disorders will take a step back?
No, I would say actually the statins are here forever. Nothing can replace the statins. Statins are the class of drugs that have been responsible in a large part for the more than 50% reduction we have seen in cardiovascular deaths in the Western world at least. And I think as we go forward in India also, these are the drugs that are going to have significant impact on the ever-increasing ischemic heart disease mortality, both in general Indian patients, but specifically in diabetic patients as well. I think statins are particularly virtuous in that they are the least expensive class of cardiovascular therapeutics, and these are agents that are consistently beneficial both for primary but particularly for secondary prevention in all kinds of patients. It is also important to note that there is hardly any class of drug in cardiology that has consistently shown beneficial effects across the world. And this is the reason all of the guidelines, whether you take American guidelines, whether you take the British guidelines, European guidelines, or even the local Indian guidelines, they have all consistently recommended that statins should be utilized in all susceptible patients, and they have all consistently emphasized that high-intensity statins particularly should be utilized in higher risk patients, such as those patients who have acute coronary syndrome, such as those who have survived a stroke, those who have been who have undergone PCI or any kind of other revascularization procedures, etc., and of course in all diabetic patients. So I think it's important to emphasize that statins are here to stay. PCSK9 inhibitor introduction is a welcome addition because despite statins, there still is some residual risk. And PCSK9 inhibitors can further lower, when added to statins, LDL cholesterol by about 50 to 60%. So it is conceivable, although we don't have the data yet, it's conceivable that statins, when PCSK9 inhibitors, when added on top of statins, will further lower cardiovascular event. I'm very fortunate that I'm serving on the steering committee of the largest trial, the 48 trial, which is being done with the first PCSK9 inhibitor, evolocumab, and we will have the results probably ready sometime in the middle of next year of 27,000 patients, 1/3 of them being diabetic. And fortunately, I was able to convince the company, so we will have about 300 patients from India in that trial as well. So that's very exciting. Furthermore, for Indian subjects, it's very important to keep in mind that we have a specific genetic abnormalities. We have high Lp(a), for which there is no treatment at the present time. PCSK9 inhibitor is the first class of drug that can lower Lp(a) by as much as 30%, which is a very welcome addition for those patients in India who have high Lp(a). So I think that is very important to keep in mind. So I would say that the most important message for my lecture today will be that statins should be utilized in all patients, particularly those who are high-risk primary prevention candidates, such as those with the Framingham risk score category of 7.5% and above 10-year event rate, in all diabetic patients, in all familial heterozygous and hypercholesterolemia patients, and clearly in all patients with atherosclerotic cardiovascular disease. And I want to emphasize atherosclerotic cardiovascular disease includes not only CHD patients, but also stroke-prone or survivors of stroke as well. A very important category because stroke in India is also increasing significantly.
Very true.
And I think particularly with the kind of treatment strategies we are using in India, revascularization gets the trump, but actually one should know that statins reduce cardiovascular event rates and improve survival as much or more than the expensive revascularization procedures.
Both the guidelines, the American as well as European, has only talking about statin as a class. They have never differentiated between atorva, rosuva or simva. So is it all three can be interchangeably used in both primary and secondary, or do you have specific experience?
No, I think that's a very good question. But I remind you that in 2013 guidelines, we define statin therapy as high intensity,
Medium.
moderate or intermediate intensity, and low intensity. Low intensity is not recommended for anybody. It's only for those patients who cannot tolerate the other doses. High intensity statins are recommended for all with ASCVD, for patients with diabetes who have either high risk for CAD or have had an event, for all FH patients, and moderate intensity is primarily recommended for patients with diabetes who are in the low risk category, and for all those who have Framingham risk score of 7.5 and above, 7.5% event rate risk over 10-year period. So I think, and when you look at the high intensity statin, there are only two statins. Atorvastatin 80 milligram, 40 or 80, most of the data is in favor of 80, or rosuvastatin 20 to 40.
True.
When moderate statin, simvastatin comes in play, because heart protection study clearly showed the beneficial effect with 40 milligram of simvastatin. And of course, you can use lower doses of both Atorva 20 to 40 or Rosuva 10 to 20 milligram. Now, of course, there is an interesting caveat there, and that is the Jupiter trial, which was a primary prevention trial, and Jupiter trial clearly showed that in patients who don't necessarily have high LDL but high CRP, essentially showing vascular inflammation, that rosuvastatin 20 milligram was highly effective, reducing the overall death rate by nearly 40%.
Sure.
And keep in mind, in Jupiter trial, 40% of the patient had metabolic syndrome, something very common in India. And I think this is very, very important to keep in mind. So I think you can, the message is that in susceptible patient, high intensity statin is the name of the game.
True. So most of the guidelines and most of the physicians and KOLs believe that statins for all above 40 is not a very practical way to go ahead. What is your take on that?
Yeah, I think that's a reasonable criticism or reasonable objection, if you will. First intervention should always be lifestyle changes, which include, of course, losing weight, which include dietary changes, pattern of dietary changes, and of course regular physical activity, at least 150 minutes every week. So I agree with that, but I think in reality, to sustain that kind of lifestyle change is very difficult.
Very difficult.
Especially in the current era of all the stress of work and high speed, sort of rapidly progressing economy, etc. in India. So I think if you cannot do it after 6 months, one should not hesitate taking a statin. In that scenario is why the universal guidelines are recommending. It was particularly emphasized in the British guidelines, the NICE guideline. They said that virtually every individual over 50 years of age is at high risk of having cardiovascular event. And that's why they said that age should be considered as a sort of marker for starting statin therapy in all.
So I think statins are here to stay, as you again re-emphasize. Newer agents like PCSK9 will definitely be helpful, but base therapy of statin will remain the mainstay of treatment, at least as of now.
Yeah, I think at the present time, we have no trials that are going on that are considered versus statin.
True.
Like the trial I mentioned to you, 4A, that's on top of a statin. The other trial going on, Odyssey, etc., they are also on top of a statin. So there is no attempt to replace a statin. We also don't know the PCSK9 inhibitor, even though they reduce LDL, we don't know whether they will have the same pleiotropic effect of a statin. We know statins have effect beyond LDL, reducing inflammation, improving endothelial function, improving thrombotic milieu by decreasing platelet aggregation, and also enhancing other intrinsic thrombotic.
PCSK9 inhibitor has not been approved as a monotherapy, I believe. So still they are approved as an add-on to statin therapy.
Yes, they are approved as monotherapy only in the FH patient, homozygous familial hypercholesterolemia. But even in those, we need both, because alone, even PCSK9 inhibitor would not bring the LDL to levels that we desire.
Correct. So thank you, sir. Thanks for joining us today. And the message is statins are the mainstay of CV therapy for both primary and secondary prevention, and they have consistently shown unquestionable benefit, and they are here to stay.
Absolutely.
Thank you, sir. Thanks a lot for joining.
So I would say actually the statins are here forever. Nothing can replace the statins. Statins are the class of drugs that have been responsible